right-hand side of the screen and save it to your desktop. I would now turn the call over to Ms. Sandra Katanik. Ms. Katanik, you may begin.
Thank you very much. I'd like to thank the audience tonight for giving up your precious time to listen to us. We hope to keep this to about an hour, and that includes the presentation, as well as about 15 minutes of questions and answers following the presentation. My name is Sandra Katanik, and I'm the CEO of the Intersocietal Accreditation Commission. And my co-presenter tonight is Ms. Rita Schugert, and Rita is the chairman of the IAC. And what we hope to accomplish tonight is to share with you the payment policies that we are aware of, and to help you understand better what laboratories may need to know in order to ensure compliance with those policies. I'd like to first start by giving a little bit of a background to the Intersocietal Accreditation Commission. This particular slide actually outlines that structure. We were started with the first organization in 1990, and that would be ICAVL, and that's for Vascular Laboratory Accreditation. In 1996, we added ICAEL, and that was for echocardiography. In 1997, the ICANL joined the Intersocietal Accreditation Commission for Nuclear Medicine, Nuclear Cardiology, and PET accreditation. And in 2000, the ICAMRL was started for magnetic resonance imaging. And in 2006, we added our latest diagnostic testing accreditation modality for CT. Each one of these organizations is governed by an individual board of directors for each division, and those boards of directors are appointed and elected through their sponsoring organizations. Now, there's a lot of organizations listed on this slide, and I'm not going to read them all to you except to give you a better understanding that our board members come from individual medical professional societies, and they are the ones responsible for writing and revising the standards as well as the individual programs for accreditation. Now, I'd like to get started by talking about some of the factors that have affected the growth of accreditation. And as you can see, items 1 through 3 actually are all the same, and so that's no real surprise. Reimbursement, probably more than any other factor, affects the accreditation receipt of applications. And pretty much we started to see this back in the mid-90s when we saw the first payment policies related to Medicare for vascular accreditation and echocardiography accreditation. Rita Schugert is going to talk much more about these, about the policies as they are today. And then we saw more private insurers start to sort of jump on the bandwagon of requiring accreditation for reimbursement, the largest of which was United Healthcare that announced in 2007 that they were going to require accreditation in 2008. And there were various other private insurers as well, and I'm going to go through a list of those this evening. And then in July of last year, we saw a federal mandate for reimbursement linked to accreditation in the MIPA law, and I will pretty much finish out the talk tonight by reviewing that. So first I'm going to talk a bit about the United policy, and this particular slide comes from a newsletter article that we published last summer, and it was related to a talk that Dr. Reed Tuckson, who's the Executive Vice President and Chief of Medical Affairs for United Health Group, gave to the United College of Cardiology in 2008. And essentially what Dr. Tuckson said was that United Healthcare believes in quality performance, measurement, and feedback. He stressed that quality measurements are key, that United Healthcare only wants the right procedures in the hands of the best labs and the best interpreters of that information. At the end of the day, it's extremely important for United Healthcare that they use the Intersocietal Accreditation Commission's criteria and others to make sure that the right folks are doing this. We will not pay for garbage studies. At the end of the day, quality measures are very important, according to Dr. Tuckson. So if you want to keep up to date on United Healthcare, and this is a national policy, so I dwell a little bit more on this because it has the ability to affect anybody from across the country. Many of you may recall that this policy was published in 2007 and revised in 2008, and the current policy, which you can see here by the date on this, was downloaded on 7/13, that was just last week, and that United will require all facilities to have submitted an application to either the IAC or the ACR by the fourth quarter of 2009. And you can get this information at unitedhealthcareonline.com. If you go to unitedhealthcareonline.com, this is actually the page that you will see. And if you go to the clinical or clinician resources, the drop-down box that will appear will have options, many options actually, but the imaging options are contained under cardiology as well as under radiology. And if you click on, as I've done here, the cardiology link, you will see the imaging accreditation link. And you click on that, and you have many options that you can choose from, documents that you can read. This particular one is a program overview that basically talks that if you are billing on a CMS 1500 form or its electronic equivalent, that you will be required to have completed and submitted an application for accreditation to either ACR or one of the IAC divisions. Now, moving on to some other private payer policies, we came across this one, and pretty literally we didn't know about it until some Tufts providers had actually faxed us the policy, that effective July 1st, 2008, Tufts providers for echocardiography had to meet at least one of these criteria, and either all the physicians were certified by the National Board of Echo, and all the staff sonographers were credentialed, or that the studies were done in a facility accredited by ICAEL. Another private payer policy that we were aware of was Anthem Blue Cross and Blue Shield of Virginia. This policy was actually made public last year and was, I believe, initially designed to go into place in March of 2009. In April of 2009, they updated the policy to make the deadline September 15th, 2009. This again is Anthem Blue Cross and Blue Shield of Virginia for CT, MRI, PET, echocardiography, and nuclear medicine. Another private payer, and not actually payer, but rather a radiology benefits manager that has requirements for accreditation as a condition for reimbursement is CareCore National. For those of you that reside in the Northeast, you are probably familiar with CareCore National, as they are the radiology benefit management company that services many of the private insurance companies in the Northeast. They actually require accreditation for CT, MRI, nuclear medicine, and ultrasound, and they recognize all of the IAC divisions as well as the ACR and as well as the AIUM for general ultrasound. Now, some other private insurers, and I think I alluded to this when I showed the Tufts policy, was this disclaimer that this list may not be complete, as very frequently we don't know the details unless one of you as a provider of imaging services calls us or faxes us that policy. So some of the other private insurers that we know that have payment policies that require accreditation are Highmark Blue Cross and Blue Shield. This is the largest private insurer in all of Pennsylvania, and they require accreditation for all of ultrasound, including vascular and echo, as well as MR, CT, nuclear medicine, and nuclear cardiology and PET. Oxford, which is now a division of United Healthcare, was one of the first private insurance companies to require accreditation for nuclear cardiology, and they put that policy in effect in 2003. Aetna in New York and New Jersey has had various payment policies since 2000 that required accreditation for various diagnostic imaging modalities, the first of which I believe was MRI, and most recently I believe they've published a new policy for echocardiography. The entire state of Rhode Island requires all of their insurance providers to require accreditation for MRI, and they recognize both ICAMRL and ACR for that. Arkansas Blue Cross and Blue Shield also on the private pay side requires accreditation for PET, CT, MRI, and nuclear, and Anthem Blue Cross and Blue Shield of Maine has a policy in place to require accreditation for echocardiography and nuclear cardiology. Now, I'm going to turn this part of the program over to Rita, as she is going to give you all of the payment policies related to Medicare for echo and vascular. Rita?
Thank you, Sandy. When it comes to the Medicare program, CMS administers its policies through the Medicare program for vascular and echo, regarding lab accreditation and personnel certification as a condition for payment through something called local coverage determinations, or LCDs. And these are the payment policies are found in these documents, LCDs, and they're contractor-specific documents that tell the providers, us, who are the circumstances under which services will be considered covered, correctly coded, and therefore paid by Medicare. And LCDs are general coverage documents that address many topics, such as the types of the exams covered, the frequency of repeat exams, documentation requirements, several different items. But they often also include requirements for the technical, medical, and interpreting staff qualifications and lab accreditation. Now, the way we find these policies is through looking on the contractors' websites. And to find the contractors, we have to know a little bit about who the contractors are. The contractors are different types of insurance companies. They're either called fiscal intermediaries, and those are insurance companies who pay claims and make policies for hospital inpatient services, which are called Part A services. Then the insurance company may be called a carrier if it pays claims and makes policies for outpatient services or Part B services. And we are now undergoing a transition to something called MACs, or Medicare Administrative Contractors, who will pay claims and make policy for both Parts A and Part B, or both hospital inpatients and outpatients within their jurisdiction. And the old system of FIs and carriers, which were two different companies, will be abandoned eventually. This transition away from FIs and carriers to MACs began in 2006 and is supposed to end by October of this year. That may be delayed a little bit longer than October, but it will be completed probably by the end of this year. So that's why you need to know these terms, because we're still operating under all three of these systems. Hospitals, inpatient services are being paid in some states by FIs, and carriers are still paying claims for outpatient services in some states if they have not yet undergone the transition to one of the 15 MACs. Now, this is a map of the United States showing the MAC jurisdictions, the 15 different insurance companies will be paying claims for Medicare services, and this is for all Medicare services, not just vascular and echo services, any type of Medicare service once the transition is complete. And for instance, you can see that I live in North Carolina, which is right here, and Palmetto GBA in jurisdiction 11 will be our contractor. It's also the contractor for South Carolina, Virginia, and West Virginia. But we have not yet undergone the transition, so right now our services are being paid either by the Part A carrier, Part A FI, or the Part B carrier. If you look out here in California and Nevada, they too have the same insurance company, Palmetto GBA in jurisdiction 1, but they have undergone the transition. So their claims are being paid by their MAC or Medicare administrative contractor. So the FI, the carrier, or now in the future, the MAC, may develop a policy or an LCD that requires lab accreditation and sometimes personnel certification as a condition of payment. And here's an example of language from the National Government Services LCD for vascular credentialing and accreditation. NGS is the MAC for the states of Connecticut and New York and also Indiana and Michigan. And while each policy or LCD has some slight variations in the language, this is fairly typical. If you will look at this part right here, this is the important part. It says all non-invasive vascular diagnostic studies must be performed under at least one of the following settings. And then it gives three different options. It can be performed by a physician who is credentialed in vascular technology, performed by a technician who is certified in vascular technology, or performed in a lab that is accredited in vascular technology. And then in this section down here, they actually list the credentials that they will accept, the RPVI, the RVT, the RCVT, RVS, and ARRT credentials, and the ACR or ICACTL accreditation. Now, for outpatient vascular lab services, which was Part B, these are the states and 3 territories that have requirements for either personnel certification or vascular or lab accreditation as a condition of payment. If you look, you'll see the, in parentheses, you'll see the jurisdiction number. These are the states. Not all states have the policy in effect yet. For instance, in these 5 states, the policy is not effective until May 1st of 2010. But it is a requirement for in these 33 states and 3 territories. In these 3 states and 3 territories here, California, Hawaii, Nevada, and these 3 territories, in jurisdiction 1, it is merely a recommendation in their LCD that the lab have accreditation or the personnel be certified. In these 14 states, there is no LCD regarding vascular services at all for Medicare patients. However, if you look, you can see that in jurisdiction 2, jurisdiction 3, and jurisdiction 14, they have until just recently had such a policy that required or recommended credentialing and or accreditation. And these policies were only recently retired or made ineffective. In 2 jurisdictions, they were retired on just in the last a month ago, and 2 months ago in another jurisdiction. Now, whether these are being revised and will become effective again, we don't know, or whether they are being permanently retired, we don't know that either. But there's a lot of change going on in these policies right now. When it comes to Part A, or hospital inpatient services for vascular services, there are now 28 states and 3 territories which require credentialing and or lab accreditation as a condition for payment. And this is quite a change from previously under the carrier and FI system, in which there were very few states and jurisdictions that had any requirements at all. So this is something that many hospital-based facilities will find a new requirement that they will need to meet. So here's some sample language from an ECHO LCD, this one from Palmetto GBA, which is the MAC for California and Nevada. And you'll notice as we go through this that the ECHO policies often have separate requirements for the technical portion of the exam and for the professional portion of the exam. Just as in the vascular lab LCD, you'll see that there are 3 conditions that are acceptable for meeting the requirement. The service for the technical portion of the exam can be performed personally by a physician with some type of training that is similar to Level 2 experience. The service can be performed by a credentialed technician, and they accept the RDCS or RCS credential, or the service can be performed in a lab that is as credentialed is what it says, although they do mean accredited, by ICAEL. And for the professional or interpretation portion of the exam, and this is for TTE and TEE, there are two conditions that will allow the requirement to be met, and that is if the physician is ABIM board certified or board eligible in cardiovascular diseases, or if a physician provides the interpretation of a study that was performed in a lab that is accredited by ICAEL. So as we saw in the vascular policies, for Part B or outpatient services for TTE, there are 7 states and 2 jurisdictions that require either credentialing and or personnel certification as a condition for reimbursement for Medicare patients. There is an LCD that applies to TTE or TEE or echocardiography services in 21 states, but they do not have a requirement for credentialing or accreditation in these 21 states here. There's no LCD addressing echocardiography services at all in these 19 states. And 3 states actually do have a policy that requires accreditation or credentialing, but the language is inaccurate in the policy because it mentions the vascular credentials and vascular accreditation, and that is simply a mistake of language that hasn't been corrected. And we do believe that their intent is to have a requirement for echo accreditation and the appropriate certification. For the inpatient services for TTE, again, we have 13 states that require accreditation and or credentialing, and then there are no requirements in these 39 states. So how can you find the LCD that may be applicable to your facility? This is a link that will take you to the CMS website, and on that website there's a list of LCDs by state. Click on that link. You will be taken to this website or to this page, and you can find your state or your jurisdiction and click on that, on your state's name. At your next page, you will actually, before you get to this page, you will actually have to decide if you are Part A or Part B. Remember that Part A is for hospital inpatient services. Part B is for outpatient services. Once you've clicked on that page, you will be brought to this page. And this page will say that it is the active LCDs, and it will tell you how many LCDs this carrier has. The carriers have different numbers of LCDs. This particular carrier, which is Cigna Government Services, or the MAX, may have any number of LCDs. Some of them have 100 and something. Some of them have 20 or 40. They can have LCDs on many, many topics. And the list of LCDs will come up beginning alphabetically with the A's. I strongly recommend that you begin in the A's and just arrow down through the alphabetical list until you get to something of interest. That's because the N's for non-invasive vascular testing, the vascular testing policies may be listed under N for non-invasive, but they may be divided and found in other sections, for instance, C for vascular testing, P for peripheral arterial or peripheral venous testing. Echo policies likewise can often be found under E for echocardiography, T for transthoracic or esophageal, and occasionally they can be found under M for medicine. So you never know exactly where you're going to find them. Once you do find the policy, you will click on this LCD ID number, and that will bring you to the actual PDF of the entire policy, and you can read that. Now, these policies are subject to change at any time. The carrier, MAC, or FI is required to review them at least annually But with the transition from the carrier and FI system to the MAC system, there has been a lot of change in these recently. So I would recommend that you go to your website, bookmark it for your jurisdiction, and check these at least every couple of months for any changes that you may find. And certainly there is a trend toward requiring accreditation, as you can see, rather than not requiring it. So I think with that, I'll close and turn things back over to Sandy.
Thank you, Rita. I'd like to point out and thank Rita for all of the research that she did. And when she talks about how quickly these policies change, I know for a fact that she had done a lot of this research in May for a seminar that she did in May, and then found pretty significant changes again when she did it for this seminar. So we strongly advise you to download this presentation so that you have that link to your website and check your own LCDs on a regular basis. So I'm going to move on now, and I'm going to preface the talk about the federal mandate by this particular slide that talks about the IAC application receipt by division. And I think it's interesting to note, if you look at the green bars, and this represents the vascular labs, and you see that those payment policies started in the mid-'80s, and so Vascular has had a very consistent application receipt over time. And you look here in 1998 when we started our very first nuclear labs in these sort of maroon bars, and you see they just chugged along at relatively low numbers, and until we got to 2003, at which time the Oxford policy came into effect, and we saw a somewhat large spike there. Likewise, in 2007 and 2008, all of the divisions, even Vascular, even though they're not included in the United policy, saw a tremendous increase in the number of applications, and we continue to see a large spike in applications even through the first half of this year. So let's move on to the federal mandate and what will be the impact of the Medicare bill regarding accreditation. Well, you'll frequently see the Medicare bill referred to as MIPA, and that's because that stands for Medicare Improvements for Patients and Providers Act of 2008. And this particular act or law requires advanced imaging accreditation by January 1st, 2012 for advanced imaging. And I want you to keep in mind why I've bolded that by, and we'll see this in another slide. Right now, I want to show you that the regulations for, or the proposed rules for accreditation were actually published just last week on July 13th, 2009 in the Federal Register. And I'm sure you'll just be rushing to the internet to download this Federal Register and read all this lovely fine print, or not, and I'll just summarize it for you related to accreditation here. And it basically, the rule states that beginning January 1st, 2012, that Medicare payment is only going to be made for the technical component of advanced diagnostic imaging services to a supplier who is accredited by an accreditation organization designated by the Secretary. That would be the Secretary of Health and Human Services. Advanced imaging is defined as diagnostic magnetic resonance imaging, computed tomography, nuclear medicine, which includes nuclear cardiology, and positron emission tomography, also known as PET. It took this language directly from the Federal Register, that CMS is not proposing at this time to include other diagnostic imaging services in this definition, and that January 1st, 2010 is the statutory deadline in order to designate those organizations to accredit the suppliers. So that means by January 1st, we will know whether or not we will be designated as an accreditation, as an organization to accredit imaging services. And all suppliers of the technical component of advanced diagnostic imaging services must be accredited by a CMS designated organization by January 1st, 2012. As you can see, this is by January 1st, 2012. Not have an application in submission, as is the United policy that you just have to have your application in, but rather you have to be granted accreditation by that deadline. Now, also included in the proposed rule is that the accreditation agencies that they designate must have knowledge and experience in the advanced diagnostic imaging arena and must reduce the burden and cost of accreditation to small and rural suppliers. There also was quite a lengthy list of ongoing responsibilities of CMS-approved accreditation organizations, of those responsibilities back to CMS, such as we must provide copies of all accreditation surveys of specific suppliers, notice of all accreditation decisions, notice of all complaints related to suppliers of advanced imaging services, information about any suppliers of the technical component of these services for which we may have denied accreditation, notice of proposed changes in our standards or our requirements or our survey process. I found this one to be quite the surprise. Permit our surveyors to serve as witnesses if CMS takes an adverse action based on accreditation findings, and also provide CMS with any written notice of any deficiency and adverse actions. We will be subject to continuing oversight by CMS through validation audits. And these audits may be a CMS team or their contractor. They will have the right to examine the results of our organization's survey procedure on site or observe our agency's survey processes in order to validate that. Also, notice of intent to withdraw approval of designating authority is a requirement for CMS. Now, CMS actually published, or CMS published as well as the final law last year, published 5 criteria that the organization that is deemed to be an accrediting organization must meet. And I'm going to go through each one of these quickly, but one by one. The first one is to conduct timely reviews of accreditation applications. And basically, we know that we will meet that as our standard accreditation review cycle has actually decreased over time, and we now average 12 to 14 weeks from when you submit your application to when you receive your decision. And we're able to achieve this because we have eliminated our quarterly deadlines, and we now accept applications at any time throughout the year. One of the other criteria is that we would have to have a process for the timely interpretation of new advanced diagnostic imaging services. And we actually just had a recent experience with this with our nuclear medicine program, our ICANL. We had received a request from some equipment manufacturers and software developers to include new equipment that had not yet been incorporated in published professional guidelines that would reduce the acquisition time in half. And so we received that request in January of 2008, and by October of 2008, our board of directors had actually approved a policy for accepting applications that are using this new type of equipment or software. Thirdly, we need to have strategies for ensuring adherence to the IAC standards. And currently, all of our divisions are incorporating either random site visits and random audits into their process. These will all be completed by the beginning of 2010. And if you are a laboratory that has been granted accreditation by an IAC division, you will either be required to undergo a random site visit or a random audit at one point in your 3-year cycle. And you will be randomly assigned to either the site visit or audit category, and you will be notified of which of those will occur and with details of what you will be required to submit. Also, for actually ensuring adherence to the standards, we needed to have in place a formal complaint mechanism so that we can receive and process complaints either from imaging professionals or from patients that have undergone imaging procedures in accredited laboratories. And we have developed an investigative hierarchy that we have published on intersocietal.org in our operational policies and procedures. We also need to take into account the capacities of suppliers located in rural areas. And when we met with CMS representatives back last year in October, this was our only concern that we expressed to them, primarily because there's nothing really concrete to determine what is rural. There are some zip code designations, but that's about it. So we also questioned CMS as to what options they thought that we should consider for rural providers. And one that we thought might be okay but would come from them would be more time to implementation of the accreditation requirement. But we suggested that we were concerned that this particular requirement might ask us to lower our standards. And we did not feel that that was a very good option for rural areas because I don't think any of us think that bad care is actually better than no care. So we've yet to receive a final determination on that. We also, by law, were required to establish reasonable fees to be charged for accreditation, and we felt that we have managed to do this over time. The IAC is a 501c6 not-for-profit organization. We are funded solely on our application fees. Those fees are reviewed annually, and they are actually based on the expenses of the programs themselves. We actually then have to make certain that we have reserves in place to fund our programs and to continue program development. And once those reserves are reached, then any excess revenue is used to improve the programs or decrease the fees. Now, the law that was published last year, as well as the proposed rules that were published last week, actually set forth 5 specific criteria that any deemed accreditation organization had to include in their program. And I'm going to briefly go through each one of these. First, the program has to include standards for the qualifications of non-physician personnel. And for each one of these 5, I'm going to show you a specific example from one of our divisions, not all of them. And all of those standards are actually published on the individual websites. So this particular one, I've posted the requirements for the technical director for ICAMRL for MR facilities. And basically, we have 2 criteria that they have to meet one of. And they can be an RT-MR, or they could have an appropriate credential in another medical imaging field and 1 year of full-time equivalent experience as an MR tech, performing at least 100 examinations. We also have to have standards for the qualifications of medical personnel. And in this particular example, I'm showing one from ICACTL, and this is the standard for medical director required experience and training. And there are actually more than 2, but in this particular slide, I'm showing 2 of the criteria that a medical director could qualify under. And one is, for instance, for cardiac CT, completion of level 2 training or equivalent, or for non-cardiac CT, interpretation of at least 100 studies and 20 hours of CT classes, and this is actually the equivalent of the cardiac level 2 training. And those can be found on the ICACTL website. Also, the law requires that the standards include performance specifications for equipment. And here, again, I've chosen to demonstrate from the CT standards just a piece of what the instrument quality assurance requirements are. Basically, if you are operating a CT laboratory and applying for CT accreditation through ICACTL, you must have a quality assurance committee. And that committee can be made up of many people, but at a minimum, you have to use a site-appointed medical physicist or qualified expert for an annual survey of the scanner image quality and dose, as well as oversight of the quality control program. And you must provide documentation at all times of that the quality control tests. Now, the 4th requirement are standards to ensure safety of personnel and patients. And here I've chosen a section from the ICAMRL standards for safety. And I did that because there are certain conditions that must be met in all MR labs to ensure both patient safety as well as personnel safety in the performance of MR exams. And the last requirement are standards for QA and QC to ensure reliability, clarity, and accuracy of the images. And here I've chosen to show the table of contents from the ICANL standards for nuclear cardiology, nuclear medicine, and PET accreditation. And you can see that I've circled Part C, Quality Improvement, and this is actually subdivided into 3 sections. And the middle section is probably the most important because it requires that you have quality improvement measures in place for administrative quality, technical quality, and physician performance monitoring quality, as well as quality improvement meetings on a regular basis. So in reviewing our standards for all of our divisions, all 5 of our divisions contain all 5 criteria that were listed in the law. So I'm going to finish up with sort of what has IAC done for me lately. We've pretty much had a year to figure out what the requirements were probably going to be deemed an accrediting body by CMS. And so we've worked pretty hard over the last year, actually probably the last 2 years, because the United Payment Policy was also a significant policy that had pretty far-reaching effects on the imaging community. So we have created a web-based online accreditation application that is active currently for 4 of our 5 divisions. Echocardiography is the only division that does not have its application online, but that's expected to take place in the beginning of next year. As I mentioned previously, we've eliminated all quarterly deadlines from all divisions. We have clinical as well as administrative staff in all divisions to answer any questions via email or phone calls. We have on-demand webcasts for all divisions that are published on the home pages of each one of our imaging divisions. We try to maintain website updates of any payment policies when they're made available to IAC. And we also provide timely email notifications of any pertinent changes and updates to any of our programs. And first I'm going to show you a little bit of what the IAC online accreditation application actually looks like. This is the profile page from an online application. And you can see here that you would go under applications depending whether you're vascular or nuclear, MR or CT. You can manage the users who can complete the application. You can identify certain people within your facility and give them access to the applications. You can manage your staff for one or all of the divisions that you may be applying for accreditation. You can manage sites if you have more than one site that you're providing imaging services at. You also can manage all of your equipment and list all of your equipment, and you can maintain this application on an ongoing basis. You also have the ability to contact us directly through the online application, and of course you can log in and log out. Some of the other things that you've probably seen from us lately is that we offer or have been offering some live webinars, and here our ICACTL program actually in May offered 2 live webinars to help facilities submit a successful application. Just today we had a webinar for ICANL that deals with our new program for emerging technologies as well. We're repeating that next Wednesday. ICAVL recently sent out an email blast to notify their members that we have no more quarterly deadlines. And we recently sent out an email blast to all of our ICAEL laboratories that would include anybody that had ever requested a newsletter or had ever completed an application or purchased an application that we will require all of our cases to be submitted in digital format next year. Now, that pretty much wraps it up for the slides. And so as a reminder, if you have a question, we would ask you to click on the Q&A. That should be at the top of your screen in your Microsoft Office live meeting screen in the main menu bar. Type in your question and then hit enter on your keyboard. We have several staff members here that are monitoring the questions. Some of you hopefully had submitted questions while we were talking. Our staff has monitored those, and Linda Howard will be asked to come on to the call, and she's going to ask several of those questions. If time does not permit us to answer all of those questions today, they will be published along with other frequently asked questions that we received at the same seminar last week. They'll be published by the end of this week on all of our IAC websites. And I'd also like to request that you take a minute at the end of this. We will send you an email with a short survey, honestly, only 3 questions, and we would ask you if you would kindly complete that, because that actually helps us for future webinars. And so here I'm going to leave up this list of how to contact us with the technical managers from each division, as well as our new address, and all of our websites are listed here. As a reminder, if you look at the top of your live meeting bar, you should see a little icon that looks like 3 sheets of paper, and that's a link to the handout that will contain all of these slides. And you will be prompted to download that, and you can save that for future reference. So, Linda, do you have some questions for us?
Hi, Sandy. Yes, I have some questions, and I just wanted to pass along some information for the attendees that they've been kind of asking about. First of all, the handouts button is located, or the handouts icon is located in the upper right-hand corner of the screen. It looks like 3 pieces of paper. You can click on that and download the slides from tonight's presentation. And also, there's much curiosity, Rita, about your link. And I'm going to put the slide up actually on the screen again. And I don't know, Rita, if maybe you have something that you would put into the search engine to get this. But many people are asking about this particular web link. Also, folks, I posted it in the Q&A list, which you can copy and paste it into a Word document for yourselves to keep it at a later date. So, Sandy, our first question is, our lab includes a mobile component. How will this be impacted by policies requiring accreditation for reimbursement?
Well, that's a good question, Linda, and it certainly is a frequently asked one, isn't it?
Yeah.
Actually, it gets asked a lot for United, and so probably what I should say is that right now with some of the private payers, particularly with United, we have a data share that we are just fine-tuning. We actually feed them data every day. That is updated by our staff, and it's an automatic update, and it is tracked by address. So when you apply for accreditation, you have the option, if you are a mobile service or provide mobile services, there's a piece of the application you must complete, and you must list every site that you go to by its address. And during your 3-year cycle, while you are accredited, you will be required to update us with any address changes, any sites that you add, any sites that you delete, because we do, as I mentioned, share that on a regular basis, and with United it's on a daily basis, any changes in address. And so they really are, for the most part, linking by address, and we have that capability in our application.
Thank you, Sandy. Let's see. How will the insurers know that our lab is accredited?
Yeah, that's pretty much the way. It basically, for the most part, at least with United, it's through that data file share. But I will tell you, for instance, we know that Highmark pretty much looks at our website, and I didn't talk about that tonight, but all of the accredited labs are listed on the websites. They're listed in the areas that they're granted accreditation in with an expiration date as well. Now, that list, particularly for mobile sites, does not include the mobile sites, and so very often Highmark, for instance, will send us regular emails and say, we've been asked to pay for a claim from this address. Can you verify that this lab is part of an accredited facility? And we turn those requests around within 24 hours. So we do have very good working relationships with many of the insurers.
Okay. Sandy, could you please clarify, you mentioned when you were showing the folks the online application page that you mentioned ICAVL being in the online application. Could you just clarify that they're not quite yet online?
But yes, I took a little bit of liberty to include that ICAVL is online. However, Linda is correct. Right now we are in beta testing with that application, and it is expected to go live. That's sort of our office speak. It is expected to be available to any vascular laboratories, either reaccredits or first-time accredits, I believe by the third week of August.
Okay. Let's see. We have a question regarding the random audit and or site visit. Each and every lab that is accredited, regardless of modality, gets audited within this 3-year period, either with a site visit or audit? That's the question.
That is correct, and we have different levels of audit, and I know that I didn't go into a lot of explanation about that. Those laboratories that are chosen for audits are then subdivided into different levels of audit. So an audit may range from nothing more than an update to the demographic information, maybe an update to equipment, an update of staff, to an audit that may require randomly selected reports from physicians or randomly selected cases. And those reports and cases would be, the dates that those would be done on would be selected by us. So there would be no option to do them ahead of time. Most of our programs require examples of best work, but the audits will require random examples of work that has already been completed.
So in follow-up to that, Sandy, is the random site visit cost paid by the lab or paid by IAC?
Very good question, Linda, because I'm sure a lot of people are thinking that out there right now. Actually, that is included in the application fee. So if you are selected for a random site visit and or a random audit, that is completely included in the cost of your initial application fee. If you are chosen to have a site visit because we cannot make the decision based upon what you have submitted because it's unclear or we're concerned about the quality of the work, that's a different type of site visit, and that is one that is paid for by the laboratory.
Okay, next question. If ICAVL started all of this, why is Vascular not considered advanced?
Yeah, I'm sure I'm hearing Rita laughing about this as well. This is an incredible disappointment to most of our colleagues in the vascular field and most of the people committed to doing quality vascular work. For whatever reason, our government officials chose to identify advanced as those types of studies that actually they probably pay more for, and not necessarily based on their complexity. And we had nothing to do with that. In fact, we have asked that question of many government officials and have yet to receive a reasonable answer.
I would maybe add, Sandy, that there is speculation that it has less to do with the technology and the testing, and that ultrasound was excluded from the NIPA legislation specifically due to some intense lobbying by some ultrasound specialties.
I think that's a fair statement, Rita.
One more question that I have. Whoops, maybe another question after this, but we'll see. If we are not accredited and will be impacted by the United Healthcare policy, when should we submit our application?
Well, we're waiting for, we actually have monthly conference calls with United and ACR. All three of us and many from our staffs are on these calls. And we're anxiously waiting for what they are going to publish as their, for lack of a better word, their drop-dead date that your application has to be submitted to us. We know now that it is the fourth quarter, but, you know, the fourth quarter can go anywhere from October 1st to December 31st. So we don't exactly know when that is. I would encourage people that are intending to comply with the United policy to consider submitting it sooner rather than later, and that way you won't be troubled by not getting it in time. As I mentioned before, it's a big difference from the federal policy in that for United, it simply requires that your application be submitted to us. And I believe they have said that you will have 1 year in which to achieve accreditation. For the federal mandate, for the MIPA requirements, you must be accredited by 2012, not in the hopper, but actually accredited. And just to speak to that for a minute more, that becomes very important because, as I said, we've actually improved our processing time from 12 to 14 weeks, but even though we can get your application and get a decision back to you within 4 months, the reality is that 50 to 70% of the applications that we review are delayed, and they're delayed for some additional material or documentation that they have to send to us. So I would allow no less than 6 months for the federal mandate to have an application in order to be granted by January 1st, 2012.
Okay. Sandy, I have one more question for you.
Okay.
It is, based on your experience, do you think all insurance companies are going to follow suit and reimburse only accredited labs?
Oh, crystal ball. I would say, why not? I think, at least in my limited understanding of insurance companies, is that most, and including radiology benefit managers as well, most like the idea of a mandatory accreditation because it does guarantee them that certain standards are being met, and then they can actually add on if they see other requirements that they want to add on in addition to accreditation. We've learned a little bit from United that part of the reason some insurance companies don't require the hospitals to be accredited is because they have contracts with them, and that to add a requirement like this could indeed nullify their contract. So I think there's probably some contractual issues that insurers right now are working through. But and I've spoken to a lot of private insurers over the last several years, and all of them agree it's a good idea. So I would say it's much more of a trend than not.
Thank you, Sandy. Just wanted to remind everyone that if you weren't here for the beginning of the presentation, we did mention that if time does not permit us to answer the questions, your questions that you've given, or the complexity of the question requires a little bit more detail, they will be published with other FAQs by the 24th on the IAC website. And we're asking everybody to remember to take the really short survey.
Okay, and I think that wraps it up, right, Linda?
Yes, thank you.
Okay. I think the operator will give some final comments, but I would definitely like to thank everybody for participating in this session tonight.